host. My guest today is Becky Grohs. She's a registered nurse, she's a case manager, she's clinical director of a program called Consistent Care. Becky, thanks for joining us today. Really appreciate that. I want you to bring that microphone a little bit closer to you. Yeah, it just moves around. There you go. Good. How are you today?
I'm good. Thanks for having me.
Good. Let me set this up, and why this topic I think is so important, and I chose to talk about it today, is that here's a couple of statistics for you. Between the time of 1999 and 2010, so that's like, 11 years, sales to hospitals, doctors, pharmacies of opioids or painkillers increased fourfold in that time period of 11 years. By 2010, pain meds prescribed were enough to keep every single American medicated for 1 month. That's a lot of painkillers. Overdose deaths have increased 300%. So I think, folks, if you have been watching the news lately, you know that people are now really starting to talk about painkiller addiction in the United States and why we have this problem, what's going on. So that's my first question to you, Becky. What happened? What changed that we have so many people abusing prescription drugs? What happened?
Well, the House of Medicine has really looked into this because, we wonder the same thing. When I was a nurse working at the hospital in the 90s, how we treated people's pain was very restrictive, and there was a lot of energy that went into identifying how to treat people's pain more effectively. And they came up with what they call the sixth vital sign, which was how to identify the level of people's pain. And there was a big push on trying to treat people's pain more effectively. We realized that we weren't doing a very good job of that. So in the late 90s, there was a big push on prescribing opioids, trying to get people more relief. And the pendulum has kind of swung the other direction now. So we're really looking at how we can treat people's pain more effectively and try to address this epidemic. Mm-hmm. It's very challenging.
So you feel it's an epidemic?
I know it's an epidemic.
Oh, okay.
That's what we call it.
Yeah, what I want you to do is I want you to describe a couple of typical cases for us so that we can create a picture in our mind of circumstances, people, what we're talking about here. What is a typical case?
Well, first of all, let me tell you briefly. What I do is I work for hospitals in several counties across Washington State to address patients that overuse the emergency room. Mm-hmm. So that's how I have become very familiar with this opioid abuse issue. So what I have is I can tell you I have a patient, and no names here, who at one point had 90 emergency room visits in 1 year.
90 in 1 year?
Yes. So that's almost 2 a week, right? And all of it was driven through her opioid addiction and mm-hmm. her desire to obtain more hydrocodone, Vicodin, Dilaudid, all of those medications. And she would come to the emergency room, she'd come up with a story, and until we identified a way to track the number of ER visits that were happening and a way to track the prescribing of prescriptions, that happened because we had no way of knowing from one side of town to the other. So for instance, we had patients that go to Catholic seeking opioids and then go over to Trio seeking opioids. Until we had these tracking systems, we had no way of knowing that they were just at the other ER 30 minutes ago mm-hmm. because we have separate healthcare systems. Mm-hmm. And so that's how that can happen. So we worked with her, we got her into treatment, and now she has 0 emergency room visits.
Wow. And
she has tackled her opioid addiction.
How old is she?
In her 20s.
20s.
So what we see is a younger class of, my typical patient is females in their late 20s.
Oh. How did this start for her or other people like her?
Well, what happens a lot of times is, it can start out innocently. It can start out as having an acute injury or maybe you've had surgery or something, and your prescriber prescribes what they feel is an appropriate amount of pain medicine. And when you talk to people who have been addicted to opioids or heroin is an opioid, they will tell you that if you're happy and you're happy at a 9 or 10, when you're on opioids and heroin, you're at a 60. Okay? you develop that tolerance, you develop that desire for that, and then it just leads you down that road.
Oh, okay. All right. So I want to understand the difference between someone who is addicted to painkillers and versus someone who is legitimately managing a chronic pain situation in their life with painkillers.
Absolutely.
Those are two different people, aren't they?
Yep, they are. And it's very challenging to try to meet the needs of the people that truly have chronic pain and prevent folks from moving into addiction and tolerance. So what I want to make sure that people understand is that you can have tolerance and dependence on opioids, but that doesn't mean you're addicted. Addiction happens when you develop what we call aberrant behaviors, which are behaviors that are indicative of addiction, just like an alcoholic. You begin to do things that you would not normally do in an effort to obtain those substances. Like steal, fraudulently write prescriptions, get them from your neighbors, get them off the street, maybe early refills. Those are signs of addiction. So it's very important that when the doctors are treating chronic pain, that they give them the lowest possible dose that's effective. And that takes work. It takes sitting down with that patient and talking to them about, is this pain medicine actually helping you lead a better life? Are you more functional? So in Washington State, back in 2007, we put together a group, and they're the Agency on Medical Directors group. And in 2007, we wrote the initial guideline, not me personally, but the Washington State doctors got together and wrote a set of guidelines that help direct providers in how to appropriately prescribe pain medication to people that are truly chronically have pain. And since then there have been a couple of new revisions, the latest one in 2015. But it sets parameters on doses that primary care providers can administer or prescribe before they send patients off to pain management specialists and those sort of things. So there's a lot of effort that goes into trying to keep that balance between people that truly have chronic pain and folks that have moved into addiction.
So I want you to tell me the names of some of these prescriptions and just how addictive are they? I mean, are some of the, they're not like, are they like heroin?
It is heroin. Heroin is an opioid. They're all opium-derived chemical compounds. So your hydrocodone, Vicodin, Lortab, oxycodone, Percocet, morphine, Dilaudid, all of those are called opiates. And they're very highly addictive. What happens is it's been determined that 1 in 4 people who have moved on to heroin started off with legitimately prescribed opioids. And we're not talking about, it can happen to folks that get them legitimately prescribed, and it can also happen to our younger kids, our kids in high school and college, who decide, I'm going to, get these from grandma's cupboard, and we're going to take it to the party this weekend. I'm going to be real popular, I'm going to hand this out, everybody's going to love me, right? And then they start liking it. And they love the high. The high is beyond any high they've experienced. And so they will get more and more. And then it moves on to heroin.
Come on, I've taken painkillers for, having some dental work done or, a small operation or whatever, and I went to sleep. I didn't get any big high out of it.
I know, I'm with you, Christine.
And sometimes they, in my own personal experience, they make you feel they make me feel really stupid.
And droggy.
They sap your energy level, and you just kind of...
Well, they're not just going home and they're not going to this party and taking one Lortab. We had a case last week where this kid took 4 hydrocodones, 3 Vicodins, a couple of benzos, and was drinking on top of it. Now that's where your overdoses come in, because they're experimenting with these drugs. And that's why it's important that, we don't have these sitting in our cupboards.
Yeah, absolutely.
Yeah.
All right. Hey, we've got a caller on the line. Let's go ahead and add that person to our conversation. Hi, you're on the air with us on this Friday.
Yeah.
What's the name of it again, please? Okay. Hey, thanks a lot for your call. That's good information for us. Have you heard of this, Becky?
No, I
Okay,
haven't.
all right.
Mm-mm.
All right. I'll tell you what, we've got to take a break here, but we're going to come back because what I want to do is talk about what the program is in the Tri-Cities or in the state of Washington, which evidently, folks, is something that other states are modeling after. What are we doing about this? I think you'll be impressed. Stay with us. Welcome back today. My guest, Becky Grohs, RN. Also, she is clinical director of a program here in the Tri-Cities called Consistent Care. She's also a case manager. We're talking about painkiller addiction. And so I want to know, Becky, now what's going on with this program in the Tri-Cities to kind of change the course of what's happening here.
Yeah. Well, very related to the opioid abuse is the efforts that are being undertaken to control overuse of our emergency rooms.
Mm-hmm.
Because we have, not that everybody that overuses the ER is seeking opioids. There's a good percentage of them that are. And it's definitely something that we have to address. It's a stewardship issue for our community resources and insurance plans. So what we started here in the Tri-Cities back in 2012 was to work for the hospitals in Benton and Franklin counties and implement legislation that was passed by the state, by the healthcare authority, in what they call the 7 best practices. And it was an effort, and it was actually a response to the healthcare authority's desire to not pay hospitals and ER providers for visits made by Medicaid clients that were not emergencies. And they actually came up with a list of conditions that were not emergencies. Now, that doesn't mean we could turn around and tell them to go to urgent care or to their primary care. We had to see them in the ER because the federal government has a mandate called EMTALA, which says you present to the emergency room with what you perceive to be an emergency, you have to be screened by a provider or a mid-level provider.
Mm-hmm.
So that was not an option. So everybody negotiated and they implemented what they call 7 best practices. And it's around the use of a prescription monitoring program. It's around the use of this health information exchange that tracks people's emergency room visits across the state. It's around giving feedback to the prescribers in the ER around their opioid prescribing. And then there's other elements to that as well. But we are leading the country in this effort. I was just in Boston last week at a national conference of emergency room physicians, and many of the topics that we were talking about was for them to learn about what we were doing, and they call it the Washington State experience. You know, what did we learn that they can also tag onto and build upon in these other states? So a lot of it is around the ER diversion, but like I said, a big piece of this is this opioid abuse. And the systems that we set in place to monitor and divert unnecessary ER visits also address this inappropriate and misuse of prescription drugs.
Mm-hmm. So, for example, I broke my arm in May, and I got a small prescription for painkillers. Is that in the system? Is my prescription that I got that and who prescribed it to me now in this database of information?
Yes. In the fall of 2011, the Department of Health created what they call a prescription monitoring program. And I think every state in the country has one. I think there's like 2 states that maybe do not have it at this time. But Washington State we developed ours in the fall of 2011, and it is to monitor and track every controlled substance fill for everyone.
Mm-hmm.
So if you get a prescription for these opioids, your benzodiazepines like your Xanax, your Valium, your sleeping pills, your Adderall for your ADHD, anything that's a controlled substance goes into this database. It's put in by the pharmacists. What this does is it allows us as a prescriber to pull up. So let's say Christine, that you didn't just get, this isn't just your first prescription.
Right. Mm-hmm.
Let's say this is your 70th prescription this year, and you have 20 different prescribers. Now I see this, I know everybody's gasping, but I see this all the time.
Still today?
Oh, absolutely.
So that means that the doctor, the prescriber, is not looking at the list. They're not bringing the information up that they have right in front of them.
That's
if
right.
they do it.
That's right.
Ooh.
And so there's a lot of effort by the Department of Health to try to get prescribers to use the PMP, which is the
Oh.
prescription monitoring program.
Absolutely.
It's a system. They have to have another password. They have to have another login. It takes time out of their busy schedule and seeing patients. So that is part of our state plan in addressing this epidemic, is to try to increase the use of this prescription monitoring program.
But they wouldn't have to do it themselves. I mean, the doctor doesn't have to do it. He can have somebody in his office or her office do it.
You have to be licensed.
To
So they
get
have
into
to
the
be an
system.
MA
Okay,
or an
okay,
L
all
or a
right,
nurse.
okay, all right.
Not a receptionist.
Okay, all right.
Yeah.
Okay. All right, so we've got a system there.
Yep.
Now it's a matter of us taking advantage of it. So I'm going to assume there's outreach to doctors and training and, you know,
Yeah, and
are there any, you know, screws put to them? I mean, is there any teeth behind this, or just doctor, you know, so-and-so, please do this?
not yet in Washington State.
Oh.
Other states have done that. Other
Mhm.
states have mandated that before writing a prescription for a controlled substance, you have to search the PMP for any history.
Mm-hmm.
We have
Okay.
not gone to that point yet in Washington State. What we have done though recently is made the prescription monitoring data available, and it's fed directly into our medical record system in the hospitals. So if you go to the emergency room, that emergency room physician doesn't have to manually go into the system and get that information. It's fed to him automatically. So if there's less effort, and it's that the information he needs to make a decision is right in front of his face. So
Oh, okay.
makes
All
it
right.
easier for him. Mhm.
All right, so I know another big part of your program is case management. How does that work?
Well, let me just briefly say what case management is.
Yeah.
So case management, and I've been doing that for about 20 years now, is looking at a patient and identifying what are their gaps, what are the cracks in their care that would lead them to better health. So sometimes that's better management of their diabetes, sometimes that's losing weight, better management of their breathing problems, but a lot of times what's keeping them from taking that next step to better health is what we call now social determinants of health. It's really hard to focus on your diabetes and take your insulin if you're homeless,
Mm-hmm.
because your goal is to have a bed to sleep in,
Yeah.
you know, and you can't get your fruits and vegetables if you have no food. And so what we do with consistent care is we identify and dig really deep into these folks' situations and determine what is it they really need. And we have revenue set aside to do things like pay for housing for a homeless alcoholic when he gets out of treatment. Because you go to treatment, you go back to the mission or to a
Mhm.
homeless shelter, how are you going to stay clean and sober?
Mm-hmm.
How are you even going to get it? You don't have a job, right? So we give them, you know, hands up, what we call hands up. Or we'll buy shoes for folks that are homeless, or we will, you know, buy food. We provide cell phones. So that's the kind of case management that we provide. It's not really just focused on the medical piece, it's the social piece as well.
Mm-hmm.
And,
And
so,
all of that is aimed at keeping people out of emergency rooms.
right,
Is that it?
right. And
Yeah. Okay.
we have between a 50 and a 60% reduction in ER visits.
Oh.
And we have folks that have upwards of 100 visits in a year. And so generally we don't look at folks unless they have at least 10 or more in a year. If you're looking at somebody with 10 visits in a year, I mean, how many times did you go to the ER last year, Christie?
Well, let's look at this year. Probably just once. That was
Yeah.
my broken arm.
Most people
Yeah.
go once every 2.5 years.
Oh, okay.
Yeah.
That's an interesting statistic. Okay. So I want to know other kinds of things that you are doing to help deal with this. And I know that you told me before about overdose kits.
Yeah.
So what is that? I think saw that on television recently. That was part of the 60 Minutes, I think,
Yeah.
that you were talking
Yeah.
about from last week. So what are those?
So Narcan is a drug. Naloxone Narcan is the brand name. Has been a we could put that in their IV and it would reverse the effects of their pain medication immediately. So now it's being used, and they've developed a formula that can be injected intranasally. So it actually has a little atomizer on it that you can spray in each nostril, and it absorbs in the mucous membranes instantly. And we did that because we want to get these Narcan kits out into the community to people at risk for overdose. So obviously, if you've overdosed on heroin or opioids, you can't do it to yourself. You're unconscious. So we really depend on the family and the friends of users to be able to really encourage that user to see their primary care and get a prescription for an overdose kit. Essentially, it has the drug in it, the atomizer, gloves, instructions on what to do and how to administer it, and then you always call 911. Now, we have a Good Samaritan law that was also passed that says, let's say you're both users and you carry an overdose kit right along with your heroin supplies,
wow.
right?
Yeah, it's planning ahead.
That's
there.
right. Well,
Yeah.
they're doing that a lot in needle exchange programs in larger urban areas.
Mhm.
They're handing out the Narcan kits with the needle exchange program, so that's part of their supplies.
So the bottom line is we're just trying to keep people alive.
That's right.
We'll deal with the fact that they have this addiction later, but let's keep you alive today.
Yep, yep. So if you have family, whether it's your child, your grandchild, your friend, an acquaintance, we need to get those overdose kits into the hands of those people.
Mhm.
I mean, I just talked to the Franklin County Deputy Coroner last week. He had 4 heroin overdoses.
4?
4. And these are young people.
Oh.
So we're not talking about your homeless guy on the street anymore. These are our kids. These are our high school students. These are college kids that are trying to get high, and they've developed a tolerance, and they've moved on to heroin.
Oh my gosh.
I hate to be so depressing, but
that
this
is.
is the facts.
It's really quite frightening.
Yeah.
And okay. So how often do these painkillers, these prescription drugs, transfer to heroin? Then I mean, once you feel like you can't get that prescription legitimately, then you turn to heroin. Is that
that's
what
right.
happens?
That's right. So our goal is to decrease the inappropriate prescribing of opioids
Mm-hmm.
to address the heroin epidemic.
Yeah. All right. Hey, let's take a break right here. When we come back, though, I want to focus our conversation on what we can do as consumers ourselves of these types of painkillers in legitimate ways, and what we can do as family members and just simply community members. We're back here on a Friday. Meet in the middle. Stay with us. Welcome back on this Friday. My guest, Becky Grohs, registered nurse, also clinical director of Consistent Care. So we've been talking about addiction to painkillers and the program here in the Tri-Cities that people are involved in. You know what's funny to me? It's not funny, but everything is all about money, Becky. And when, for example, we tell hospitals that we're not going to pay you for this, then we all, as a system, get real motivated to do something about it. And it's, you know, it wouldn't motivate us to like get people off these, you know, addictive painkillers. But if we're not going to pay you for it, then we'll do something.
Money
But anyway,
speaks. Yeah.
we are doing something. So let's focus on what we can do as families, consumers, people who live in our community. What can I do?
Okay, that's great. I'm glad you brought that up. I wanted to share some information about some take back, what we call take back initiatives. So take back means we want to have places for folks that have cupboards full of old prescriptions, specifically controlled substance prescriptions like the painkillers and the anxiety medications and sleeping pills. But we really don't want you flushing them down the toilet. It goes into the water system, and we don't want you throwing them in the garbage. It would be better if we had more places to be able to dispose of those safely.
Mm-hmm.
And until now, we really haven't had anything in our community. We did an organization called Benton County Substance Abuse Coalition applied for a grant and received a large grant in order to put in place large metal, it has to be large metal containers that are bolted to the ground that are, you know, because it will contain large amounts of controlled substances.
Mhm.
So there's a lot of regulations around that put in place by the DEA, and so it's really created a barrier to us just being able to just take them back anywhere. But now, starting in December, folks can take those old prescriptions to either Pasco Police Department or Kennewick Police Department in December and dispose of those anytime during office hours.
Anytime during the month of December.
Well, it's starting in December. I don't have an exact start date. I just
Okay,
found out
all right.
this morning that both those police departments did agree to hold the container, and then they'll dispose of them through the incinerator, through their evidence process.
Oh, so they're going to burn them.
Yep. They're going to burn them.
Okay.
Yep.
All right. So you know, I know that we have done take back days before. People bring them on a particular day, and those seem to be pretty successful. People seem to like this opportunity, this place to bring these things that they don't want anymore.
Mm-hmm.
And why is it important for us to do that?
Well, I hear stories all the time of children, grandchildren that go through your medicine cabinet. They know what the labels look like. They know what's hydrocodone. And maybe they won't take the whole bottle, but they'll take some out of it. And then they'll go about their business. You know, there actually are stories of folks knocking on the door. They don't want to scare anybody, but knocking on the door, asking to use their bathroom, and going through their cupboards. This is an addiction. They'll do a lot of things to obtain these medications. And so we have to do our part to keep our community safe. There's going to be a large take back event January 9th at the Cadlick Healthplex, and there they will be dispersing individual lock boxes. So that's something that you can do if you are a chronic pain patient or you have regular prescriptions of these other controlled substances. It's a small box. It has a little dial on the top that with a 4-digit code that only you or whoever your caregiver is has access to. But then you put your controlled substances in those lock boxes. So we're really encouraging folks that have these medications that they take regularly to have these small lock boxes. And they're going to be giving those away on January 9th at the Cadlick Healthplex. They're going to give away 750 of those.
Wow. Okay,
yes.
That's quite a few.
Yes, you just have to undergo this small educational piece to learn about, you know, how to protect others around you, and then you'll be given those boxes.
Mm-hmm. So, you know, another thing, I'm going to guess that people who are addicted and have that addictive behavior and are constantly looking for pain medications, they know what doctors are more likely to prescribe than others. I also read something that oftentimes 80% of the prescriptions are written by only 20% of the medical doctors. So we are monitoring and retraining and doctors today. Have we seen a decrease in prescriptions?
I haven't seen a decrease yet. We have seen somewhat of a plateau, but we have not in the last couple of years.
Why?
Well, it takes a while. It's taken us a while to get to this point. It's going to take a little bit to reverse it.
So we just don't want to be uncomfortable for the shortest period of time. I mean, we can look at that in dental care as well. I mean, wow, we just don't want to be uncomfortable.
Right, and let me tell you a statistic that's relevant to that. In the United States as a country, we're responsible for 5% of the world's population, but we're responsible for 100% of the world's consumption of hydrocodone and 80% of the world's consumption of oxycodone.
Oh my gosh. Okay.
Okay, does that tell you anything about Americans?
Yes, we
Yes.
always want to be comfortable.
Yes.
Yeah. And we want to be high, I guess. Okay, that's just really frightening. All right. So this Narcan, I'm going back to things that we can do here. Narcan, but it has to be a prescription. So how do we, let's say we have a family member. I mean, would we go to our doctor and we say, I need a prescription for this so that my daughter Janie isn't going to overdose in my house, or what?
What we're trying
Can I get that?
Well, we're working on that.
Okay.
Not a lot of pharmacies actually carry the Narcan vial. There's the hospital pharmacies all do. So we've worked to get both Cadlick and Lourdes emergency rooms to have overdose kits in their ERs. So when a patient presents either having had an overdose or at risk for an overdose, we distribute them to their family and friends that are in the room. However, right now, what needs to happen is if you are at risk for an overdose, and I'm not just talking about the people that are, you know, using heroin, these are people that are on high dose chronic opioid treatment. Those people are also at risk for overdose, and they should be talking to both their pain management specialist and their primary care doctor about having access to this overdose kit in their home. So right now, we're getting it from primary care providers. There's a big push across the state as well, they passed a law that allows us to distribute overdose kits in other places other than the doctor's office and the pharmacy. So you'll be able to distribute them through schools, social service agencies, fire departments. There are many, Snohomish County is one of them where I have another office. They are distributing them out of their police cars. So they're really dropping the barriers down so that we can increase access to these overdose kits.
If you have had experience with this, maybe a family member or you yourself, why don't you give us a call and tell us some of these experiences. Our phone number here is 547-8726. So when we stop using these painkillers, is there a process of withdrawal like other drugs? I mean, to get off of them, do we have to go through this process of withdrawal?
Right. We have a couple of options. First of all, I want to make it clear that alcohol and benzodiazepines, which are the drugs that are used to treat anxiety, like Valium and Xanax, both of those can be very dangerous to come off of. They can be deadly. However, opioids, if that's your only drug, opioids, coming off of that's going to be very uncomfortable. You're going to have withdrawal symptoms, but it's not going to kill you. Okay? So,
good.
So I just want to distinguish between those different kinds of drugs. Fortunately, part of the National Drug Control Policy that's coming out is to increase the prevalence and availability of a drug called Suboxone or Subutex, buprenorphine. It is a drug that's is a type of an opioid, but it's what we call medication-assisted treatment for the treatment of opioid addiction. And we do have providers both here in Benton and Franklin counties and in Yakima, Spokane. The clinic's called, I'll say it, it's Ideal Option. They're our only Suboxone provider. And you can see them and they will not only provide you the medication to slowly get off of these opioids, but also the substance abuse counseling that makes the drug much more effective. And so part of the push nationally is to increase the number of patients that each Suboxone provider can see. Up until now, there's been limits on how many patients each doctor can treat. We don't want to have those kind of barriers. So the president is really pushing to open that up.
Well, our exposure to this the painkiller addiction is much greater today than it ever has been. I mean, we're learning about it so much more. Did you see the viral piece of video that has been out there from presidential candidate Christie, who talked about a friend of his in New Jersey, who is a very, very successful man, had all the elements of being a success, a great career, great educational background, lovely wife, beautiful children, great job, on, had some kind of a back injury, got painkillers, became addicted to the painkillers, essentially from that lost everything. If you have a chance to listen to that Christie piece of video, and he's talking, I think, kind of in like a town hall setting, it's very, very interesting in that this was a friend of his who then lost everything and ended up overdosing and dying. I mean, his life just went in the toilet, basically. And you know, it happens to people that sometimes we identify them as being weak, or we don't give them the same kind of treatment or acknowledgement that we might to somebody who has cancer, for example. That's the position that Christie took, which I thought was very generous, and that we need more of in our society to get people basically off this stuff. Because it affects our entire culture. I mean, we're paying for it. We're losing people, and people steal from us, and we have to pay for all of this as a society as well. All right, we're going to take a break here. John's indicating. We'll be back in a moment, so please stay with us here on this Friday on who is Becky Grohs. Becky, what are some of the numbers about Benton County, our own community that we live in here, in terms of painkiller or heroin addiction overdoses that we know about, deaths?
Sure. The statewide rate for overdose deaths related to any opioid, whether it's heroin or prescription painkillers, is at 8.6. We are under that. We are at 7.6. So it's 7.6 deaths per 100,000 residents. However, that has increased from 4.3 in 2004. So that reflects a 75.5% increase in overdose deaths in that amount of time. Another statistic that's really interesting is the crime lab cases. So we look at crime lab data to kind of reflect, in a rough sort of way, the amount of opioids that are out in the streets and out in the communities. So these are any encounters with law enforcement that were the result of an opioid or a heroin. And that has increased 321% in Benton County.
Ooh.
Yeah, it's huge.
Okay. All right.
So the rate went from 11.8 to 49.9 in the same amount of time in the last 9 years. So that has significantly increased, which, like I said, is just a rough estimate of what we've got out on the streets.
So we know we have a problem. Yeah. So police are seeing it as well.
Yes.
The police, the coroners, the emergency rooms. Yeah.
Right. So what we need to do better at, I believe personally, is we need to work alongside our law enforcement and our justice system to work together and address this problem. Because we're all in our silos. You know, law enforcement does what they do, and medicine does what they do. But really, a lot of times, these are the same folks that they're dealing with. When they're out on scene with an opioid-related encounter, they might see prescription bottles with other people's names on them. We need to know about that, because here on this, at the same time, we're out prescribing these opioids to the same people that are what we call diverting them out on the street. So somehow, both of those entities need to come together and come up with a solution.
But we are, I want you to tell me, I want there to be that we are making headway in this. Are we not at the point yet that we can say that we are making headway?
Well, it depends on how you define headway. I think some element of headway is acknowledgement of the problem.
Okay. Good.
So
all right.
there's definitely acknowledgement both at the national and statewide levels. In fact, we just created a draft statewide plan to address this epidemic across Washington State that just, it's hot off the press. And so the acknowledgement and the fact that a lot of entities are coming together to address it is progress. You know, it's going to take time.
Well, it's good to know that Washington is one of the leading states in the country. I guess that is a little bit of a sense of comfort that we will do something about it. We have good intentions to do that. I want to move a little bit to the family situation. Oftentimes families know what's going on, and sometimes they're even enablers. And we have learned so much more about that because of programs on TV like Intervention. But is intervention a reasonable method for a family to pursue, where people all get together and decide that they're going to confront one of their family members or a friend with this information and ask them to seek help?
That's interesting you should ask me that, because I just had this conversation with my medical director yesterday. He has a contact in Spokane, what you would call an interventionalist, that does the same thing like we see on TV. And what he just recently told him is that he doesn't do that anymore. He doesn't do those interventions anymore like we see on TV. He's found that those are less effective. So what we need to do is love these people despite their illness, and we need to try to get them to realize the impact it's making on their lives and everyone else's lives. The first step in treatment is acceptance that there's an addiction, and the process would be to get what we call a chemical dependency assessment, and that's generally obtained from substance abuse providers out in our community, and we have a lot of them. And it takes about a 2-hour process, and they sit down, the user sits down with the what we call chemical dependency professional, and they run through a series of questions, and the outcome is whether or not they need outpatient, intensive outpatient, or inpatient treatment. But that's really what gets the ball rolling, is that chemical dependency assessment. And just because they get an assessment doesn't mean that they are committing to treatment. Okay, it's a start. And if we can get our families or friends to agree to at least do an assessment, then that gets it started.
Yeah. Where can families go if people are listening today and they're like, I'm motivated, I want to find out more? Where do I go?
They can always call Crisis Response.
Mhm.
Crisis Response, I think it's 783-0500. They have substance abuse counselors there who can either do the CD assessment or direct them to where they can get the services.
All right. Becky Grohs, thank you so much. I really appreciate you talking with us today about opioid addiction and its epidemic here in the United States and certainly in our community. We are back to wrap up this Friday in just a moment.